So good afternoon, everybody, or good evening or good morning, depending from where you are joining. My name is Roxy, and I'm working at the ReSViNET Foundation, and it is my honor to welcome you all here today. As this is the first time that we are hosting this webinar on the Teams platform, I would like to take a little bit of your time to explain to you how the discussion part will work. After Mark Miller's presentation that will be introduced shortly, we encourage you all to participate in an interactive discussion by asking your questions in the Q&A box on top of your screen. And that is if you are joining through the Teams app. If you are joining us through the browser, you can ask your questions in the chat, and we will make sure that they end up with Mark to be answered. So having said that, it is now my honor to introduce to you our host, Harish Nair. Harish is a professor of pediatric infectious diseases and global health at the University of Edinburgh, and he is also a ReSViNET member of the scientific board. And last year he was awarded with the Barney Graham Award for his inspirational contributions to the world of RSV. So it is my pleasure to give the floor to you, Harish, and thank you for being here.
Thank you, Roxy. And it's my pleasure to be with you all today and to chair and introduce our speaker for today's webinar. So what is it that we do at the ReSViNET Foundation? So this was set up, the foundation itself was set up about 10 years ago. And I can still remember how 9 of us with Louis together set up the ReSViNET Foundation. And we then reaffirmed these goals and our vision and mission a few years ago, and we find that all of it is still relevant. So the vision is to connect global expertise and leadership in order to decrease the global burden of RSV. And our mission is to support performance of high quality research, improve knowledge of RSV epidemiology, and to help develop safe and effective therapeutic and preventive interventions. What do we want to do as part of the ReSViNET Foundation? We want to advocate and create awareness of RSV, and you would have seen a lot of activity around this that the foundation did earlier this month during the RSV Awareness Week. We also want to act as a focal point for effective partnerships with stakeholders and then combine knowledge and capacity to enhance the development of novel RSV therapeutics. So why do we even bother doing any research and creating awareness for RSV? Well, as you all know, out with malaria in under 5 children, RSV is the single most important cause, is the largest contributor to child mortality. So globally, about 100,000 children under the age of 5 years die from RSV. 99% of these are in developing countries. But apart from death itself, in terms of disease burden, about 33 million cases of RSV every year, and these are all lower respiratory infections, and 3 million hospitalizations from RSV, and the overwhelming majority of the severe cases and deaths, more than 50%, are in children younger than 6 months of age. So it's been almost a couple of years now since this webinar series started, and we've done 10 webinars so far. So what was the objective around the webinar series? There's a lot of activity happening in RSV at the moment, lots of new developments and lots of new research, and it's difficult for anyone, even for someone like me who is immersed in RSV to keep abreast of all that is happening. So what we want to do is promote knowledge sharing on around the latest developments and publications on groundbreaking studies. And you must be having sight of some of the ReSViNET papers of the month that we put out from time to time. But also, we want to educate all the professionals, researchers in the field of RSV, and also the lay public about RSV. So these webinars happen once every 2 months with some breaks around the conference time and also during the holidays. And as I said, we've had done 10 webinars so far. On an average, we have about 100 live participants. And the average experience of this has been very, very good. People have rated 4.8 out of 5. We have global representation. Until now, we've had participants from all 5 continents and from 440 countries. And as I said, part of it, our work is trying to create awareness and also educate the lay public. So for the lay audience, we have a translation of the scientific seminar that is done by Dr. Leakey. So for this seminar that we have today, we will have a webinar in January 2023 that is presented by Dr. Leakey. And these lay webinars have also been very, very popular. And the next webinar then is going to be in April 2022. The speaker and topic are to be confirmed. So why are we having the next webinar only in April 2022? Well, that is because we've got the next RSV conference, the ReSViNET conference, or the RSV Vaccines for the World conference in 2023 in February in Lisbon, and this is going to be a face-to-face event, and this is going to be the 7th ReSViNET conference. We've got a very rich scientific program and sessions ranging from burden of disease and mortality to global epidemiology of RSV to clinical development to health economics. So, and I think this is going to be very interesting for a whole range of scientists who are working in RSV. They've been very popular. The previous conference that was held in Accra in Ghana in 2019 was attended by over 350 attendees, and for the Lisbon conference already we've have over 150 attendees who've confirmed participation. So at this conference, in these ReSViNET conferences, we try and also focus on the next generation. So we've got some sessions that are focused on young researchers. We have a young researchers tournament. We also have master classes. The deadline to submit the abstract is in about a week's time. So on the 1st of December, the abstract submission deadline closes. We already have abstracts for from over 90 participants, and so if you intend to submit an abstract for a poster, then please do submit your abstract before the deadline. And we also had a travel grant award for young researchers that was put out earlier, and that's closed now. So important thing is the conference is in Lisbon. It's a nice city. It's worth visiting. And the more details are available on the ReSViNET website. So do go to the website and do remember to register as soon as possible. So with that, I will move on to today's webinar. So today's webinar is by Dr. Mark Miller. So Mark Miller is now retired, but previously he was the associate director at the Fogarty International Center at the National Institutes of Health in Bethesda. He was also the director of the Division of International Epidemiology and Population Studies there. And Mark has worked on a range of infectious diseases, and it's in the context of RSV that I met Mark for the first time, I think almost a decade ago at the ECDC. And Mark has continued to be engaged with us in different ways, including as International Scientific Advisory Group member for the Rescue Project and the Promise Project that we lead. So over to you, Mark, and we look forward to hearing your interesting talk on the public health perspectives of RSV.
Thank you, Harish, and Lewis and the other organizers, and thanks for the opportunity to talk about the public health perspective of RSV control. And over the next 25 minutes, I'll try to explore with you about how health and individual liberties are valued in society to influence the public health policy formulation, and how we make decisions regarding the use of some of the tools that we've created in the scientific community for implementation on the population base level. So essentially, how can we use health economics and observational discipline, which can help us to understand the behavior and motivations regarding the use of vaccines? I'll review some history of vaccine implementation, health economics concepts, and some of the terminology as it relates to how we make decisions for vaccine policies, and open it up then for general discussions relevant to RSV current issues. Again, I'd like to emphasize that public health equals population health, and population health is science and politics, which require an understanding of the individual and collective values. RSV immunotherapy and vaccines are just one tools for communicable disease control, and they compete frequently with other things for our focused attentions. So how can we best understand that and make decisions for the use of these new tools? So for the best appreciation of this talk, I'm going to ask you to, rather than look at yourself as a person with a vested interest in RSV, put yourself in the position of a dispassionate anthropologist, observer, looking at various different societies and how decisions are being made. And throughout history, more people are believed to have perished from infectious diseases than armed conflict. So what is the role of the community, government regulation, and international collective action at various different levels of resolution with the goal of preventing morbidity and mortality of communicable diseases? In other words, if we have these tools to help to address a problem, how best can we get them to be utilized? So throughout the last 200 years, there's been a great recognition of the role of microbes in the respiratory and enteric pathogens which cause death, and many of these are listed here. In the words of Susan and Stanley Plotkin from the text on vaccines, the impact of vaccination on the health of the world's people is hard to exaggerate. With the exception of safe water, probably no other modality has had such a major effect on the mortality reduction and population growth. But is this readily appreciated by the population at large? Well, we've seen the introduction of vaccines in the past, and there have been numerous examples of the impact of vaccines on the health of populations. And they've been documented numerous times with the demonstration, for example, of here a time series charts, such as the one you see here for measles introduction, and the exponential decline of vaccines of measles, consequently followed by rubella and mumps as well. Over the last centuries, communicable diseases were very apparent killers throughout history, killing upwards of 20% of all of children under 5, with the pestilence of enteric organisms in the summer, respiratory viruses in the winter, and periodic pandemics due to influenza and, of course, more recently due to COVID. Governments have looked at these problems and expended funds for public health measures in the form of water and sanitation, food hygiene systems for enteric organisms, and vaccines against smallpox, diphtheria, pertussis, tetanus, measles, polio, and TB. And they've eliminated the endemicity of most of these agents in many parts of the world, as well as eradicating smallpox. We're left with the residual number of diseases, but a smaller and smaller group of these diseases. And in this context, we're also looking at RSV. So after smallpox was eradicated, further global and national support for the universal usage of vaccines led to the implementation of national vaccine programs. For example, the expanded program for immunization, or EPI, in many nations supported by UNICEF, the World Health Organization, other multilateral organizations and foundations, with increasing recognition of the need for global mutual support in mechanisms for microbe disease surveillance and funding to control communicable diseases in an interconnected world. And this led over the last 20 or 30 years to vast amounts of programs and monies being used for the implementation of new vaccines over the course of the last number of years. But with the recognition of the benefits of vaccines and scientific discovery of microbes and immunological systems and programs to support the purchase and administration of vaccines, the programs have become far more complex in their delivery and the perception and valuation by different elements within local populations. For example, this slide shows the complexity of the vaccine schedule for infants through 18-year-olds in the United States. Vaccines which are provided to several million healthy individuals on an annual basis in the context of a normal inherent background of morbidity states, which are temporarily associated with routine vaccine schedules and therefore may be frequently confused as vaccine adverse events. So essentially, the vaccine community and vaccinologists have become victims of their own success. With the great decrease of all of these diseases, we've seen now vaccines given for the most part to healthy individuals, the reduction of these diseases completely. However, the perception of the vaccine effects is frequently lost over time. We'll get into that a little bit later. Increasingly, a greater need has developed to understand and recognize the potential utility of disease control through the use of vaccines, especially for diseases which are not readily apparent or poorly understood, and RSV falls within this category. There's been a lack of appreciation of public understanding of science, biology, and the role of communities and governments to mitigate communicable diseases of various severity. And COVID has been an incredible example of that, and the response to COVID vaccine, both for better and for worse in various different populations throughout the world. So when we talk about investing in prevention, we're looking at trying to assess a policy. And essentially, governments will need to decide on the value of RSV disease reduction balanced by the cost to society from public action. These all have various financial, social, and political costs, and the quantitative models can be used to try to measure the value of utility of these costs, providing methods to quantify explicit and implicit values and expressing them in relative terms. Governments do what they do with either political self-interest on the individual and collective level. And RSV policies will be interesting as they roll out, given that there are various tools that may be used, including therapeutic immunotherapy. So rather than just concentrate just on a national program, one has to look at that in the context of also individual therapies. So when diseases were very visible, for example, iron lungs and the chronic manifestations of lameness from poliomyelitis, public-private philanthropy and cell culture technology helped to develop vaccines, as in the 1950s and 60s. The same was true for rash illness, such as measles, which had greater than 90% incidence in children under 5. Other diseases had a more difficult time for recognition as severe, for example, varicella with rash illness, but a more modest severity. Influenza and RSV represent an interesting challenge as they're not readily apparently measured, and therefore population perception is lacking. So how do we look at the steps in an RSV policy analysis for the use of vaccines or other therapies? First, we have to define the question and what are the relevant outcomes, define the perspective of who we're asking, formulate different models, look at determining the assumptions of the epidemiologic and economic ranges of burden, effectiveness, costs, and benefits from prevention, look at the define a time perspective of how one looks at the disease over time, of incrementally increasing RSV control versus what it was before there was any type of control. And we have to test the robustness of our particular models, varying the assumptions for different populations and evaluating the uncertainty. Every population is different in its own way in terms of its epidemiology and economics, so we have to test what we see in various different populations. If we look at the epidemiology of the disease, the first step is to define the question and relevant outcome. How severe is this disease in terms of outpatient, inpatient, ICU setting, long-term sequelae, if any identified, or death? How communicable and potentially disruptive is it? What age group is affected? Infants? What age by week or month relative to when vaccines are potentially administered? And this is relevant for two reasons. Number one, when can infants possibly mount an adequate protective immune response? And two, whether the incidence of the infection precedes the period of potential vaccine-induced immunity. The first factor is a biological one. The second may be influenced by population densities, with increased earlier infections with greater population density. If the peak incidence of severe disease is in the first months of life or in premature infants, then that may imply an alternative strategy looking at maternal vaccination. So one has to account for various different epidemiological phenomena in different populations. Are there special groups that have higher levels of disease warranting targeted programs, such as those individuals with congenital heart and lung diseases, prematurity, or special groups of the elderly with chronic diseases? And also, how do we address the sensitivities of targeted populations, such as those at lower socioeconomic status, which may have worse health outcomes? And how do we then address the utility of a vaccine program in various different populations? What are the relevant outcomes that we need to measure in any type of policy analysis? We have to look at the outcome measures of importance. What's the immunity profile of the population, of the protection of the population percentage over a specific level that might be required? For example, we may not need 100% immunity in the population, especially with less communicable diseases. We can look at the number of cases that occur or are prevented by an intervention, which may be stratified by severity and sequelae. How many deaths would occur? This is easily quantified, but it defies economic evaluation. We can look at years of potential life lost, quality adjusted life years or disability adjusted life years for diseases which cause some type of morbidity as opposed to just mortality. And finally, we can look at outbreaks, the disruption of societal functions, and what is the potential value of preventing outbreaks. We have to look at defining the perspective and recognize that many partners are involved, each with their own perspective. Many public goods have overlapping and competing interests. So if we look at first the costs and the benefits from each individual component, we can look at that for the individual and public health orientation, which may be similar or divergent from each other's interests. So, for example, manufacturers might have interest in the public and the private groups. However, there are some elements of overlapping interests that we can look at, and overall we can look at societal interests at large, which try to capture all of the particular players. We have to recognize that there is different accounting of costs and benefits to each of these different perspectives. How do we define a model for a disease? And taking into account the natural history and the disease control. So here's an example for a viral disease, for example, measles. It could well be for RSV as well, where individuals are born, they're immune for the first course of life due to maternal antibodies, and then they become susceptible. They can either go into a type of model of what we call the susceptibility infectious recovery type of model, where they're either vaccinated and they become immune, as we're shown here on the bottom, without any disease, or they can develop an infection, in which case they can develop into a case, infect others, or go back to be susceptible throughout life. We try to categorize these different states into different types of cases, deaths, and measure morbidity and mortality, adding it up and going through iterative type of models throughout life, the life course of an individual and society. We try to account also for the cost of vaccines, looking at generally accepted accounting principles to look at the fixed administration for vaccine programs. What does it cost to implement a program in terms of the training, the personnel, the allocation of different time, storage of equipment, allocation of partial costs, public health education, marketing, communication, surveillance of the impact, and also taking into account the recurrent costs, the operational cost of a particular program, vaccines and wastage, syringe and needles, patient times and efforts, and then finally adverse events, and whether or not they are actually real and caused by the particular vaccine, or they are temporarily associated, and therefore we have to rule out the fact that events which are naturally occurring are caused by a vaccine or not, but have an intrinsic cost both to the program and also to the perception of value of the particular vaccine. We can look at what is actually prevented. The use of a vaccine prevents diseases. We can talk about the microeconomic. For RSV, we can talk about the direct cost of pharmaceutical costs, diagnostics, providers, etc., the chronic disability which may well occur due to long-term respiratory disease, and how can we get an appropriate accountability of that chronic disease which may or may not be caused by an acute infection. We can look at the indirect cost, for example, the cost of lost wages due to a caregiver. Frequently, RSV is in infants, so there are no lost wages. However, those who are taking care of individuals, there's time expenditures that are cost. The intangible costs, such as social costs and deaths, and then the macroeconomics of outbreaks, the disruption of the healthcare system when RSV routine epidemics, seasonal epidemics affect the healthcare delivery in the pediatric wards. We also have to look at the discounting, how to adjust for time. This is for diseases which may well occur in the future. So where does RSV fit in? This was one of the headlines actually from the Washington Post from yesterday. RSV is not normally on the general public's awareness, but it does cause the endemic seasonal disruptions in pediatric general and ICU wards. The valuation of RSV is not only in the prevention of the individual cases, but also in the prevention of these seasonal disruptive epidemics. And that's probably one of the greatest influences that we can look at is the outbreak disruptions. How do we take into account aspects of a vaccine program over time? Societal values perceive change dramatically over time. As the disease burden declines through the use of a vaccine, the perceived value relative to adverse events increase. So for example, if this is talking about RSV over the course of time, if we have disease incidence represented by the red and the vaccine coverage goes up, we have a background of decline of the disease, and over the course of time, we see a background rate of adverse events. Whether or not they are due to the vaccine or not, the perception is that the vaccine, which is now given to a relatively healthy population, is potentially causing adverse events. Whether it is true or not, it's still temporarily associated, and the perception of value of a vaccine goes down in time. So this is a perfect example for what has happened with measles. Prior to measles vaccine introduction, pretty much the entire population under 5 had a rash illness. With the disappearance of measles disease, the perception of the vaccine declines in time. I would argue that this happens with most vaccines, and therefore it's important to understand the different perspectives of time over the course of the use of a vaccine. So if we look at the value of prevention, we can analyze a number of different factors. We can look at a cost analysis. What is the actual cost of a particular program in a population by just looking at before and after? What's the benefit? What is the change and reduction of disease, and what's the economic savings essentially from use of a vaccine? If we look at the change of the cost divided by the health outcome, that's what we call a cost effectiveness type of analysis, of just basically dividing the how much does it cost divided by the benefit. The cost utility puts it into a term of a common metric. If we're looking at a new implementation of a vaccine, how do we compare the cost of prevention of RSV disease versus that of another? And therefore, we have a common metric term such as a cost utility, a quality adjusted life year, or a disability adjusted life year. It's a way to make a comparison of one health intervention versus another. A cost benefit is simply just putting it all into monetary terms and can be expressed whether or not it's a net benefit over a cost or essentially a cost savings by use of a particular intervention or as a ratio. One can look at something called a decision analysis and to evaluate alternative strategies. In the case of RSV, it's to evaluate a universal RSV strategy for a vaccine versus immunotherapy for those at highest risk versus a combination of the two. And finally, a sensitivity analysis. All of our models rely on a particular range of assumptions, and how robust are our models and findings in the settings of varying the range of plausible values for our assumptions. If we start to look at these type of interventions, we can start to make an investment case and put in policy priorities by measuring a variety of different vaccine options. And this just shows the context of introduction of new antigens, a combination or boosters of different vaccines, whether it be a national program is trying to decide for the introduction of HPV vaccines, human papillomavirus, meningococcal vaccines, pneumococcal vaccines, newer formulations with greater serotypes, COVID vaccines and which population to strategize, or new RSV vaccines. By looking at the various different factors of how much disease burden is there for any one particular disease, what's the particular vaccine program cost, what's the prevented disease that would be implemented by the different vaccines, the treatment savings, and the cost effectiveness. And to a certain extent, from the perspective of a healthcare system, this is the type of grid which public health officials, vaccine managers can implicitly or explicitly fill out to determine their best course of action for their particular programs. They can look at the cost effectiveness of alternative strategies, for example, maternal vaccination for RSV or immunotherapies. So although many vaccines have been considered cost-effective, why has there been a delay in their adoption into routine vaccination programs in many countries? So what are the particular barriers and the perceptions of a vaccine value which lead to either their implementation or not? So we started to look at this a number of years ago to look at factors which affected the probability of new vaccines introduction. And if we look at this in a systems way of approach, and a quantitative approach to looking at prevention effectiveness of vaccines, we can look at the number of cases prevented, for example, RSV. It's a function of a number of different factors. First of all, it's a function of how much disease burden is there actually perceived or really there, the efficacy of an intervention, whatever it might be, and there may well be various different interventions, and then what would be the coverage or implementation rate of that particular intervention. So for disease burden, one can look at surveillance and literature, and that's one of the programs that the ReSViNET program and PROMISE have been doing, has been reviewing the disease burden that's out there in various different populations and subgroups, and looking at also recognizing the fact that these diseases do change the incidence with control interventions. The efficacy of randomized control trials and post-licensure observance of vaccines and their implementation demonstrate the efficacy and the effectiveness of a particular type of program. And then finally, the coverage. The coverage of a program is a function of three particular factors. What's the technical feasibility of delivering a vaccine, the political, and the economic? And we're going to break those particular factors down into three, into more detail. Looking at coverage factors, the technical is a function of the operational factors. How readily apparent can vaccines be introduced into a population? What's the program feasibility? The human resources that are able to implement a new vaccine into an existing infrastructure. What's the political support? What's the perception of the disease burden amongst the ministries of health or other particular agencies within the community? Because ultimately, to implement a vaccine or prevent a disease, it's really a perception of how much disease there actually is. What's the community acceptance of a particular vaccine or a program? It's a function of trust, education, coercion, or mandates. And that's where we frequently get in trouble when programs are mandated on population. No one likes to be told what to do, and it's far better to instill the trust and education of populations. And then finally, economic. Which is a function of the financial commitment of the government or the local populations, the opportunity costs or the trade-offs for other particular programs, and the willingness to pay. And again, that's very, very different depending on the population at large and how much resources they have at their disposal. All of these factors change with respect to time. And remember that perspective chart that I had shown with looking at perception of values change over time. With the disappearance of disease, frequently the perception of the value of the intervention also goes down. So if we look at this systematically and we look at other vaccines, we started to do this systematically for other vaccines such as hepatitis B, which was a vaccine which was introduced into national immunization programs back in the early 90s with the World Health Assembly resolution in 1992 to introduce hepatitis B vaccine. And this just shows how many countries adopted that vaccine by year. Rather a smaller number. As of 1998, for example, about 6-7 years after the program or recommendation to use hepatitis B vaccine, only about 75 of 179 countries or territories used this vaccine. So we started to look systematically, what were the characteristics of those countries who adopted the vaccine versus those that did not? And these were the factors that were associated with hepatitis B vaccine uptake into the national schedules. And this looked at each of these particular variables, the highest quartile versus the lowest quartile, and what the odds ratio was of the adoption of this vaccine. For example, the countries where the treatment cost for hepatitis B was greatest, they were 5 times more likely to use the vaccine. The countries where the years of life lost, which of course took into account the life expectancy and the relative value of hepatitis B, were about 7 times more likely to use that vaccine. But by far and large, the most important factor was the coverage. The coverage rate of other vaccines indicated that those countries that had good infrastructure were 55 times more likely to adopt hepatitis B vaccine. And also finally, economics, the per capita gross domestic product, where it was greatest relative to the vaccine cost, were about 40 times as likely. So this just suggested what were particular factors that could be worked on and which could be influenced over the short term. So for example, to influence coverage, one can work with the target audience of the vaccine programs, ministries of health, ministries of finance to help support the commitments, communities to understand the utility of the vaccine, management, and operational research for delivery of vaccines. The vaccine cost to the public sector, working with manufacturers and partner agencies, and around this time, we had the opportunity to influence and get some large foundations, most notably the Gates Foundation, interested in vaccines, and therefore the support of developing the program called Gavi, which has been a major support of working with manufacturers and partner agencies to get prices that are more accessible for populations throughout the world. And finally, looking at the perceptions of the disease burden, working with ministries of health, ministries of finance, and academia, and very much what this, for example, this program is doing today. One of the major factors. So how is this all relevant for RSV? And with regard to vaccination studies and programs, there are over 9,000 published articles of RSV and cost effectiveness, over 2,000 reviews to help evaluate and justify various different strategies in quite a number of populations. How do we sort out these issues, which of course are very, very local in the context of vaccines? So we try to do this to a certain extent by looking at a few particular factors. And for disease burden, our outstanding moderator today led a study to look at the global burden of acute lower respiratory infections, and in 2005, an estimated 33.8 million cases of RSV associated ALRI occurred worldwide in children younger than 5 years of age, which represents about 22% of ALRI episodes. At least 3.4 million severe episodes required hospital admissions, and an estimated 66,000 to 199,000 children deaths were estimated. 99% of these deaths occurred in developing countries. The incidence and mortality can vary substantially from year to year in any one of these particular settings. But getting an idea of RSV and the degree of the disease burden is the critical important step of getting attention to this particular disease. RSV is an important cause of death in childhood from ALRI, and it's only third to pneumococcal pneumonia and H. flu type B. The cost effectiveness of RSV vaccines. Again, there's limited data out there as far as the utility of vaccines in population, but so most of these studies were based on modeling efforts. And the utility of RSV is a major cause of acute respiratory infectious diseases. Therefore, the mortality rates are going to dictate very much the utility of the RSV vaccine usage. The RSV vaccination in infants, the cost effectiveness is dependent on the schedules, the efficacy, the inclusion of out-of-pocket expenses, and the vaccine cost itself. Many of these aspects are still have to be assumed until there are actual licensed products. So alternative strategies are being suggested as well, given the fact that RSV frequently the greatest incidence is and severity is in the younger age population. Maternal vaccination strategy represents another possibility to prevent early infant RSV disease. This potentially would and could either complement or compete against the strategy of maternal monoclonal antibody administration. And a global economic evaluation comparing these two strategies reported that both are likely to be cost-effective in many countries. And the analysis predicted that the monoclonal antibodies would be more cost-effective, but this was compared to a vaccine that didn't have very high efficacy. However, all of these studies highlighted the potential for a maternal immunization program for a vaccine with substantially higher efficacy. There are many interesting issues regarding maternal immunization. Again, vaccinating healthy mothers with who are pregnant has its challenges, and this also has to be weighed in consideration of programs to prevent RSV in infants. And lastly, for senior adult populations, 2 studies evaluate the potential utility of immunization programs targeting older persons and the elderly, and both found that under certain circumstances this might be an economically reasonable approach, but it depends, again, on the model values for RSV-associated mortality, life expectancy, determination of qualities in the elderly population, and the duration of immunity, as well as disease incidence. Improved diagnostics in recent studies indicate that there may well be a several-fold higher incidence in older persons to help to justify immunization. The ReSViNET program and now the PROMISE program has been really instrumental in establishing the value and strategies for RSV through support of systematic, retrospective, and prospective studies, and highlighting these findings through publications and aided by foundations such as the ReSViNET is what brings you here today, and this is ultimately the strategy that we need to focus on. The importance here is to use science along with advocacy, but science-based advocacy, which is the most important aspect, to educate the population. Because ultimately, who decides what is particularly best? Science is competing to a certain extent with what else is out there. And what else is out there is what's frequently seen in the social media and the challenges that that we have with that. Frequently we hear the words, do your own research, and how to address issues of how we decide what is best and how to best educate the populations at large. We did this previously for programs that were related through influenza. Back in 2001, when influenza was hardly recognized as a major problem, we launched something called the Multinational Influenza Seasonal Mortality Study, which looked at all respiratory pathogens, including RSV, bringing together microbiologists, physicians, epidemiologists, public health officials, industry, academics to systematically support such studies to help to recognize influenza and other respiratory pathogens such as pneumococcal and RSV. So in conclusion, vaccine programs are inherently political, requiring valuations to guide public resources allocation decisions. They require the explicit statements of the benefits and individually and collectively an understanding of inaction. Modeling tools that integrate epidemiological values aid to help look at vaccine impact and optimize strategies. The process of modeling defines uncertainties and therefore the important parameters for research, of which, for example, ReSViNET and PROMISE are undertaking. The analyses are best conducted with local epidemiological and economic data for outcome relevance to local population, and modeling tools are available and essential. So with that, I will open it up and thank you to the organizers, and open it up for other questions.
Thank you, Mark, for the excellent talk. We're now into the Q&A session. And I have the first question here, Mark, for you from Lorian Harrington at the GSK. And Lorian says, regarding the reviewing the burden through literature to inform decision making, how can countries without local disease burden data make this assessment? Is there an acceptability in the scope of RSV, particularly for future vaccines if they're approved, to rely on other countries' burden data?
That's an excellent question, Lauren, and I would say absolutely. When Haemophilus influenza type B vaccine was introduced, there were relatively few incidence studies that were done throughout the world. And I argued at that time that rather than do an incidence study in every single country in the world to provide disease burden, one has to start to extrapolate as best as we can. And in time, we will get better data. There was a paucity of data from Asia, for example, at the time for Hib, and questions about whether or not disease was really there, or whether or not there was different patterns of prescribing antibiotics prevented the isolation of the organism, but they had the disease readily there as well. So I would argue that there are representational populations throughout the world. RSV is interesting because, like measles, varicella, rapidly transmissible viral agents, it's presumed to be a very high background rate of disease, but it's not measured readily. But I do think that there are tools and workshops and programs such as ReSViNET, which can help to promote a better understanding of local populations. Thank you.
Thank you, Mark. I'd like to ask a question of my own. So I was thinking, for RSV, what we're going to have is we're going to have multiple products that may be licensed in the next 4 or 5 years. We'll have different kinds of maternal vaccines, so ranging from the sort of more traditional sort of subunit kind of vaccines. We may see, for example, mRNA vaccines. We would also have monoclonal antibodies for infants. We would possibly have some pediatric vaccines. And then we are going to very likely have vaccines that are licensed in the older adult population. So, and then again, there may be multiple products that may become available. So how does a country make a decision on what particular vaccine or vaccines they would want to go for? Is there any kind of a guidebook that may be there based on your experience for other diseases in the past that you would think that the countries might be following over?
That's really an excellent question. The fact that we might have a plethora of interventions that are available at the same time, and with limited data from efficacy trials, for example, as opposed to phase 4 effectiveness. Over time, there will be greater data, perhaps from effectiveness and post-licensure surveillance of the impact of these vaccines, but they're expensive and they're not readily done. I'm looking at the similarity that we had in Europe right now with a program called DRIVE, which was to measure the effectiveness of various different influenza vaccines in populations. Influenza is a little bit different in that every single year it's a different formulation and a different virus, as opposed to RSV, which is a bit more stable. I think there will be challenges, in other words, to try to make a decision. What we did a number of years ago with our MISMS project is we held local meetings throughout the world. We had about 15 or 16 of these workshops where individuals, public health officials, epidemiologists, et cetera, came together to discuss the disease burden. We worked with models, we made them readily available, and had discussions during these 4 or 5 day workshops where local data was presented and discussed, and eventually led to publications as well, which helped to drive some of the decisions. But it's not easy, especially on one hand, it's not easy to evaluate every single type of interaction, every type of intervention. However, we're blessed if we do have so many choices in many ways. But too many choices shouldn't lead to inaction.
Thank you, Mark. We've got another couple of minutes for questions, if anyone wanted to ask a question. So there's another question that has come through. I think that has come through in chat, possibly. Yes. So this is from Malcolm McCartney, and he asks, how do we change the perception that RSV is only serious in the pediatric age group, and awareness that not only it affects the pediatric age group, but also the elderly, and that it is as serious as seasonal flu?
That's an excellent question as well. And interestingly, we had the opposite problem with influenza again, where people thought about influenza in the elderly population, but didn't recognize that it was also occurring in young children. Here we have the opposite. And the key issue here is better diagnostics. I made an allusion at the end when I was talking about RSV vaccine in adults, that more recent studies have shown that with improved diagnostics and readily apparent diagnoses for flu, RSV, COVID, et cetera, that we can get a better handle. I think it's imperative that we understand the seasonality effect of RSV. And I do believe that over the course of time, with better research projects looking at surveillance specifically and routine surveillance for RSV in the context of seasonal respiratory illness, we'll get a better appreciation of RSV in adults. That, and also working with the academic community's internists as opposed to the pediatricians. And certainly there's more awareness now than before, and I suspect with better diagnostics it will improve in time as well.
Thank you, Mark. I think we are now coming up to the end of our time, and so it is important that we continue this conversation, this dialogue. So as I said, the next webinar is going to be in April 2023, and we have the RSV Vaccines for the World Congress in Lisbon, 22nd to 24th of February 2023. It's an in-person conference, and I'm sure all of you who work in RSV enjoyed the Belfast conference. So this will be another opportunity to hear of some very exciting developments in the field of RSV that have happened, particularly around RSV therapeutics and immunization, and also to catch up with your friends and your peers. So do register for the conference, do turn up, and wishing you all happy holidays whenever they come. I know for the our colleagues from the US, holidays are just beginning, at least the Thanksgiving holidays. So have lovely holidays and have a good Christmas, and we'll see you all in the new year in Lisbon. Bye.
Yes, thank you, Harish and Mark, so much. On behalf of the ReSViNET Foundation, we're really grateful for your involvement, and I would like to ask all the participants. I shared a link in the chat to evaluate this webinar. We're always looking for ways to improve, so if you have any suggestions, please share them. And thank you very much for your attendance, and have a good evening all.